exercise, exercise, exercise. Spend time with your partner if you're in a relationship, and make sure that you're focusing on yourself. For the women out there who, are of childbearing age, and sometimes you focus on your career too much, and then you come to see me when you're 42 years old and you're wondering why you're not pregnant. I had a friend who turned 40 last year, and unfortunately got diagnosed with breast cancer. And she was crying, crying, crying. And I said, I know you want to have kids. Have you thought about ovarian preservation? Has anyone talked to you about that? And she said, what are you talking about? And I said, you should go talk to an infertility specialist about whether or not they can retrieve your ovaries and perhaps preserve them if you can afford to. And she asked me, do you tell your patients to do that? I wasn't until a year ago. And so it's something to think about. I'm not saying you should go get your eggs and freeze them, but just to know that I've told somebody to make sure that you've thought about, your career, fine, but it's better to be pregnant at 45 with a 30-year-old's eggs than with a 45-year-old's eggs. And so if one of you listens to me and thinks about that, I've done her a good service. It depends. So if you've never had any abnormal pap smears, never had a procedure called a LEAP or conization where you're taking out a chunk of your cervix for an abnormal pap smear, then you do not need a pap smear. If, however, you were a DES, just who knows what a DES baby is? So if you were exposed, if your mother was exposed to DES and then you ended up, having a hysterectomy, we still recommend pap smears. We don't do HPV testing in such patients because the type of cancer you get has nothing to do with the HPV virus. If, however, you have had a LEAP or a cone for what we call moderate or severe dysplasia, then yes, we still want you to have pap smears for at least 20 years after the time when you had that abnormal pap smear that led us to do the cold knife conization. Doing things that kind of decrease your stress. I mean, there are people who, if you're African American, for example, you're at a higher risk of having hypertension. But certainly, lifestyle, modifications like exercise, having a healthy diet. But then doing things like yoga, Reiki, Tai Chi, things that will kind of help you de-stress. I think can all help to decrease your blood pressure. The only thing you can't change, though, is sometimes genetics are just the way they are. Yes, so the average age for menopause is age 51. Before we consider you as a patient who has what we call premature menopause, you would have to be under age 40, which means that you could be 40, 41 years old, and once your cycle stops, if you've had 12 months of no menstrual cycle, you're officially postmenopausal. Once we diagnose you as a postmenopausal woman, if you then start having vaginal bleeding, the question arises, well, what is that coming from? Most patients who have postmenopausal bleeding have it from what we call atrophy. Everything's kind of dried up, and it can be so dry that eventually you have some spotting. But sometimes you can have heavy, heavy bleeding because you have fibroids, which don't kill you. The things that I worry about, that I'm thinking about whenever you're postmenopausal and you come to see me in the office is, do you have cancer or precancer? So, the things that we call precancer of the endometrial lining would be things like endometrial hyperplasia. Sounds like a big word, but those cells basically are normal cells, and over time you have an overgrowth, and those normal cells decide they want to be like unruly teenagers and start doing things that they're not supposed to do. And then we usually will have endometrial biopsy or sampling inside your uterus to look for those types of abnormal cells. And if we do see them, we actually recommend a hysterectomy, or we can sometimes give you a medicine called progesterone that can help to keep those cells at bay and regulate your cycle. So if you do have cancer postmenopausally, then of course we have to take out that uterus and hope that it's not far advanced enough that we're having you do radiation or chemotherapy. I am absolutely wholehearted for it. And I was very happy when I found that now it's not just girls who can get it, it's boys. It doesn't make any sense if a girl may be having intercourse with a boy and she has a vaccine and he doesn't. There's no sense in that. The HPV vaccine now is instead of a quadrivalent, which means it covers against the 4 HPVs, now covers 9. But there's like 100 different types of HPV out there. So certainly the HPV vaccine, if you get it, it is not a license to go have unprotected sex because you still can. All we're trying to do is to, again, mitigate risk. So we're trying to vaccinate against the most common HPVs that cause the most harm, but it also vaccinates against the low-risk HPVs that can cause genital warts, for example. And as of, I want to say October of 2018, the age limits where we can get HPV vaccine increased. So it used to be before you had to be between age 9 and 26, but now you can be 45. So guess who went to get her HPV vaccine when I heard about that? So I have one more and then I'm good. So I'm obviously less than 45 years old. But very important. My son has gotten his, so if I'm okay with my child getting his vaccine, I think you should be too. Unfortunately, there's no screening test for ovarian cancer. This is why it's very important that you should come to see your OBGYN or your family practitioner or internal medicine doctor every year. Some patients will come to me asking, well, my mom had ovarian cancer, my sister had it, so can you do an ultrasound and check a CA-125 level every year? That is not the right answer to try to figure out what's going on. There are some genetic testing, and certainly Dr. Leonard can go into that as well. Depending on what your family history is, we may be able to do certain genetic testing like the BRCA test and other ones. And if you are at risk, then perhaps we may be doing a prophylactic oophorectomy, meaning removing the ovaries, sometimes moving the breast, depending on what you have and where you are in your lifespan. If you do come in and you're giving me some, very vague symptoms, I've had increased abdominal girth, I'm not eating, I'm not overeating, I'm exercising, and you're at, the 50 to 60 age range, you could have ovarian cancer. I call that the silent killer. And so depending on what you tell me, even though I'm not doing a pap smear every year, I listen carefully. And I might decide I'm going to order an ultrasound or a CT scan looking for ovarian cancer. I wouldn't say that it's normal, but it's common. So a lot of times your libido goes down, perhaps because you have painful intercourse. And so I use the analogy of if I came to you with a hammer and try to attack your knee, really try to hit you, would you come back to me? If I came back the next day with a hammer, what are you going to do? It's almost like you feel pain and you run away. Yeah. Then maybe you think about me and you're in pain. I didn't do anything to you. The same thing can occur with your libido. If you have vaginal dryness for whatever reason, it could be from a chronic vaginal infection. It could be because you are getting into the postmenopausal range where your estrogen levels are now lower and you start having pain. Why would you want to have sex if it hurts? That's just, that's a no-brainer for me. And then sometimes there could be some chemical imbalance. You could have, hypothyroidism or other, endocrinology disorders that could just make you have low libido. You could be depressed. You could have some interpersonal issues going on. And as crazy as it sounds, I talk about this with my patients all the time, maybe your husband didn't do the dishes one day. And you're like, oh yeah? Well. And then next thing you know, it's like 6 months later, and it was something so little as that 6 months ago, and it just keeps engendering over and over and over again, and then maybe you resent each other, and then you don't want to do it, then you're dry, and then you do it and it hurts, then you really don't want to do it, and then before you know it, you're 50, and then you don't use the vagina, you lose it, so then when you do, maybe things get better, he's doing the dishes, but everything is shriveled up a little bit, and then you try to have sex and it hurts, and then it's all over. Also, you always ask me the question when you come for your one-woman exam, and 25 minutes have passed, and I have 3 minutes left. Yeah. And I have to then sit down, and that's why it takes a long time to see Dr. Wexler, because I can't just let you go. But I kind of have to figure out there are different causes. So, I try to get to know you a little bit, find out, are you sexually active? Does your husband have, sexual dysfunction or erectile dysfunction? Do you have any organic reasons why you should have, the decreased libido or, the pain? Do you have other medical problems that could be causing this, like a side effect of certain medications that we take? Certain antidepressants will decrease your libido as well. So it's not an easy question to answer, not an easy question to fix, but certainly I think I can fix it. It's partly here, but I'll just make it very open-ended. Listen, you're in your 40s. A lot of patients come to me, and they tend to have this complaint. Do you have that issue? Just to kind of broach it and make it easier, because it is a hard thing to talk about. You don't know me from Adam. Why would you trust me with something so personal? You could, I have to figure out if what you have is what we call stress incontinence, where you jump, you sneeze, you cough, and you leak on yourself, or is it urge incontinence, where your bladder gets full really quickly, and every 30 to 60 minutes you have that urge to urinate and you can't do anything. So if you have stress incontinence, that's something that we can fix surgically, but and I love operating, but before I go the surgical route, I try to get you to do different things. If you have a lot of weight, I don't care if you have a big booty, but any weight over here is going to be pressing on your bladder. So your intra-abdominal pressure, when it becomes higher than your intravesical, or the pressure inside your bladder, that pressure is going to make you leak. Just like pregnant women tend to leak because there's a big thing there. The same thing when you have weight on your belly. So losing weight is helpful. And of course the next question is, well, how am I going to lose weight if I leak every time I lose weight? You may have to wear a pad for a while. You may do exercises in the pool. Kegel exercises are very, well, it has chlorine, so I think you're okay. So Kegel exercises are very important for stress and actually for urge incontinence. I got frustrated with asking patients to, squeeze, pretend you're trying to hold your pee or your fart or your poop and squeeze, and half the time they're like doing this. So now I tell my patients to use what we call Kegel weights. They look like little balls and they have different sizes. You place it vaginally, so you have that kind of biofeedback where your brain knows that there's something cold in the vagina that you're trying to squeeze, as opposed to squeezing air. So doing those exercises are very helpful. And then, sometimes you may need to see a pelvic floor physical therapist to try to help with getting those muscles nice and strong. For urge incontinence, I treat that with medication, and then I do bladder training. So you have to basically train your brain not to think about urinating when you put your hand on the door or when you're about to, walk into your house. So, things like maybe before you exercise, empty your bladder, limit your water intake right before exercise. Drink up afterwards, of course. Modify your behavior a bit so that you can do what you like to do. Well, a lot of the providers at MedStar Montgomery are actually trying to get together. We have, our M&Ms where we discuss common issues, or we have lectures actually every Thursday to be exact. And then for women's health, we do have a group of providers too who share a common interest in women's health to try to get to know each other, so that if a patient has an issue, hey, I know, Dr. McDonald, I know Dr. Leonard, let me call her. I have her cell phone number. I can text her at maybe not 2 a.m. in the morning, but I've texted pretty late to ask that question to try to help the patients. So we have a common electronic medical record. So if I send the patient to ortho, I don't have to wait for him to fax that report. I can see it right away. He can send me a note, really short note saying, hey, I saw your patient, is what I think, read my note. And so I think that is very helpful to us. When you do have multiple medical problems, don't just, yes, we think silo care is important. It's very important that you involve your primary care doctor.
Always.
So you have to tell, that person can be that, that gatekeeper who knows that Dr. Leonard ordered it. I might not know that the medicine I gave you could, have some kind of bad interaction with what she gave you. Or maybe she doesn't know either, and your primary care doctor knows you have hypertension, for example. So making sure that you also take some control of your care and letting at least somebody who's knowledgeable, like your primary care, your internist or your family practitioner, know that you're seeing a gynecologist and an orthopedic surgeon and a breast surgeon and a dermatologist. So that person knows, oh, let me just make sure that I have those doctors' notes, and then I can, use my brain power to figure out if there's some contraindication to maybe you have depression or something else, and that medicine could be causing some side effect that could be causing ill to something else. So I love for you to see me, but I'm not a primary care doctor. See your primary care doctor as well, because that person could save you from something such that you think is not important, that I may not think is important, but they see the big picture. We sometimes are in our own lanes, so seeing someone who can see the big picture, still see us, I think will help you.